So good afternoon, everybody, dear colleagues connected to this second webinar of the year of the European Society of Cardiac Radiology. Today we will focus on hybrid cardiac imaging. We have a special guest and expert in this technique with Professor Francesco Caubelli. He works in Switzerland, he works in Basel, is an assistant professor of nuclear medicine and responsible for nuclear cardiovascular imaging, and really a prominent figure of this field of interest in Europe. The topic we will discuss, and please, again, for those of you following your first webinar, but also for the others more experienced, you can interact with the platform, with myself. I will read your messages and will forward possible questions to Professor Caubelli. The topic is hybrid cardiac imaging, and he will try to tell us whether is it a toy or a workhorse. Thank you very much, Federico. Welcome. We promise we won't speak Italian. We both are from Italy, but it's still a European webinar. Thank you so much.
Okay. So I will keep the promise. Good afternoon, everybody, and thank you for participating into this webinar. During this webinar, we'll discuss the role of hybrid imaging in cardiovascular medicine. So just to make a small introduction, so in the latest years, there is an evidence of increased interest in these methodologies, but we should understand actually whether they are only funny toys or whether we can consider them, let's say that, as a workhorse, helping to drive the diagnostic approach toward the future. And first of all, okay, we have to understand what we mean for cardiac hybrid imaging. So while it is intuitive, the cardiac hybrid imaging combines different imaging modalities, it is also important to point out that this combination should be performed ideally in a way where both modalities equally contribute to image information. So it's quite difficult to see a really equal contribution when we speak about hybrid methodologies, but anyway, ideally both modalities should be equally worth of what we are going to see. And this picture, in my opinion, explains very well the role of hybrid imaging. So in the first image here, we can see many branches covered with snow. And this is actually what we see normally when we see the anatomy of a cardiac. But if we add, let's say, colors. In this picture, then we are able to see a little bird, and however, if we only had the red color on the picture, then we wouldn't see anything but a red blob, but without any information on what it is. And this is the principle of hybrid images. So to combine two methodologies which would be limited standalone, and to yield the most useful information from both. So let's start with one of the most important topics in cardiovascular imaging, that is the coronary artery disease. According to the latest statistic, we can say that more than 50 million people aged over 20 in the USA are affected by coronary artery disease. And although coronary artery disease mortality rates have declined over the past 4 decades in Western countries, still this condition remains responsible for about 1/3 of all deaths in individuals over age 35. And as the declining mortality rates relies mostly on advanced healthcare systems, so allowing for an early diagnosis and an effective therapy, it's clear that the role of cardiovascular imaging in this regard is crucial. This is the well-known ischemic cascade, and this concept assumes that with an increasing mismatch between coronary blood flow and myocardial oxygen demand, coronary stenosis will elicit functional consequences in the supplied myocardium. Well, that is to say, changes of perfusion, diastolic or systolic wall motion, and electrocardiogram alterations. And the last step of this cascade is the clinical manifestation as chest pain. Each of these steps, of course, should be correctly identified, and a diagnostic technique should meet specific needs. Specifically, a methodology should be able to provide an early diagnosis. The image-derived diagnosis should be ideally absolutely accurate and not less important. The ideal diagnostic technique should be non-invasive, and last but not least, a prognostic assessment derived from imaging findings would be highly desirable. With this regard, the anatomic approach suffers from evident and several limitations. Well, first, the angiographic severity of coronary lesions has been reported to be often a poor predictor of its hemodynamic relevance. And considering coronary CT, which has been demonstrated even to have high correlation to invasive coronary angiography, only a proportion of stenosis are associated with myocardial ischemia. Furthermore, we can also observe that coronary CT often shows a tendency to overestimate the degree of stenosis, especially in the presence of dense calcified plaques, and which is a so-called blooming artifact, resulting in lower positive predictive value. Given the limitations of the anatomical approach, I could say that a shift to the functional approach should be desirable. Well, for example, if we consider ischemia as a potential determinant of heart failure, we have some powerful tools to determine the extent of myocardial ischemia. Well, that is to say, up to now, the myocardial perfusion imaging. And we also have the possibility, once the myocardial infarction has been diagnosed, also to perform a viability study using various radiopharmaceutical, also to assess the presence and extent of hibernating myocardium. And finally, ECG-gated images also can provide useful information about myocardial volumes and global and regional function. So far, so good. So we can say, okay, it is a perfect methodology because we can trace functional changes. But actually, of course, functional imaging also suffers from other kind of limitation too. I will cite only the most relevant conditions now, able to influence the results of myocardial perfusion imaging. First of all, false perfusion defects may be related to soft tissue attenuation, motion artifacts, extracardial activity, left bundle branch block, and so on. Not to forget, also diagnostic problems for myocardial perfusion imaging are presented by increasing number of obese patients, as well as patients with extensive and multivessel coronary artery disease. And also patients with endothelial dysfunction are a diagnostic challenge in our department. Specifically in obese subjects, SPECT is prone to false positive results due to non-uniform photon attenuation. And in patients with multivessel coronary artery disease, SPECT underestimates the true extent of disease, as the techniques also emphasizes the territory supplied by the most severe stenosis. And so, considering SPECT, we also have to acknowledge that we have a limited spatial resolution, and this limited spatial resolution also prevents us to evaluate small differences in myocardial perfusion. And the radio exposure is also a classical issue of nuclear cardiology techniques, although the recent advantages in hardware, software, and instrumentation allowed for a dramatic reduction of the delivered activity to patient. And finally, such techniques are still limited to tertiary care centers, although widely deployed in the US and in Europe. But still, the wider deployment is not so large as other techniques. Nuclear cardiology has significantly improved over the past decades. So in the 70s, nuclear cardiology was rather rudimental, even if important information could also be provided about myocardial perfusion. Here we have two examples of rest stress myocardial perfusion imaging performed with SPECT, with scintigraphy, using Calcium-43 as perfusor agent. As you can see, well, image quality is really at stake, but still we can see the difference, we can appreciate the difference between rest conditions and stress conditions. As a consequence, as the image quality was so poor, a great degree of knowledge and practice was required to interpret an examination. Today, on the contrary, we have the opportunity to have diagnostic information capitalizing on improved image quality and on the possibility of combining anatomical and functional data. And this allows for obtaining a highly comprehensive clinical evaluation. In this picture, for example, we can see that we have an area of reduced count consistent with ischemia, and this vascular territory is supplied by an artery which is constricted by a myocardial bridge. So combining the two information, we can have a very, very good clinical assessment. I will now show you how the use of hybrid spec CT system can improve confidence and reduce the number of equivocal studies, mainly by reducing the impact of artifacts. In this image, you can see a typical myocardial perfusion imaging with the system EB. And these images were obtained only with SPECT without the CT component. And there is evidence here, you can see, of a reduction on counts, both on stress conditions and in rest condition, inferior and infralaterally. And this might be confused as a scar, and the information as to whether we have a real scar or not relies now on the experience of the reader. Well, an experienced nuclear medicine physician would pose the question, do we have a soft tissue attenuation here? And if we add CT-based attenuation correction, we see that above-mentioned reduction in counts disappears completely, thus revealing the presence of soft tissue attenuation. So although an experienced nuclear medicine physician can of course exclude the presence of a significant scar with a good degree of certainty, still the concurrent application of attenuation correction allows for excluding it with a higher degree of confidence. And the important role of attenuation correction based on CT acquisition in myocardial perfusion imaging has also been elucidated by Malnernecker and colleagues. The number of equivocal studies is significantly decreased if a CT-based attenuation correction was applied. And this held true also in comparison to prone images, which were the only possibility to limit the incidence of attenuation artifacts, because before hybrid spec CT systems were available. And with my working group, we also confirmed the effectiveness of attenuation correction even in cardiac dedicated SPECT cameras. And this is a representative image from, this is a representative image from a patient with coronary artery disease and known severe stenosis affecting LAD. It was a 90% stenosis. So uncorrected images, so here and here, show a severe count reduction in LAD territory, so anterosepto-apically, and which partially recovers in rest conditions. Well, there is, however, uncertainty as to whether a perfusion defect can also be diagnosed in the territory of RCA. And images corrected for attenuation here confirm a reversible perfusion defect whose size appears anyway to be better defined in comparison to uncorrected images, and also can exclude any defects in the vascular territory of right coronary artery. This translates, of course, into improved diagnostic accuracy in the detection of coronary artery disease. And specifically, there is an evidence of a dramatic improvement in specificity at expenses of a non-significant decrease in sensitivity. And to a lesser extent, there is also a gain in positive predictive value and in negative predictive value. There is also another problem when evaluating myocardial perfusion imaging. So traditionally, how can we integrate more coronary morphology and functional information? So normally we do it by performing a so-called mental co-registration. So we use standardized myocardial segmentation models which allocate each myocardial segment to one of the three main coronary arteries. But as a matter of fact, so coronary artery anatomy varies considerably among individuals and may also disagree with standardized vascular territories in about 72% of patients. As such, the incremental value of hybrid cardiac imaging relies in the accurate spatial co-localization of myocardial perfusion defects and subtending coronary arteries. And in this example, sorry, I touched the wrong button. So in this example, the myocardial perfusion SPECT shows a reversible anteroapical perfusion defect. On computed tomography, angiography, so a complete occlusion of the proximal left anterior descending artery can be observed. And as a distal vessel opacification is present, we also may hypothesize that a collateralization is present. And the hybrid volume rendered SPECT CT images here demonstrate that the anteroapical ischemic territory is supplied by the occluded left anterior descending artery. And finally here, the invasive angiogram confirms the total occlusion of the proximal left anterior descending artery. And this was a very good example of integrating various methodologies to have a comprehensive evaluation of the situation. We may, however, speculate that hybrid system is not needed actually. So, and standalone modalities might also be evaluated separately, and information may also be later integrated. But, however, two studies demonstrated the superiority of hybrid systems over standalone modalities. Here, for example, in the study of Santana and co-workers, the detection and localization of coronary artery disease was done using myocardial perfusion imaging alone. It was done with myocardial perfusion imaging and computed tomography angiography, but side by side, and with fusion of myocardial perfusion imaging and computed tomography angiography. And the authors also really demonstrated that a significant improvement in diagnostic accuracy is achieved if myocardial perfusion imaging and computed tomography angiography are fused and simultaneously evaluated. And following this study, also Swamka and co-workers demonstrated that hybrid SPECT-CT, SPECT coupled with coronary CT, provided incremental value over standalone MPS. And we can also say that hybrid systems allow for a more accurate prediction of events as compared to standalone modalities. So in this interesting study, the Kaplan-Meier survival curves here, both in a per patient and in a per vessel analysis, they show that we have a very interesting predictive value. So people with a positive examination have, as already known, have increased risk, have increased rate of cardiac events, but still there is a large difference between based on the presence of abnormalities in both SPECT and coronary CT, or just in one of them. And this can be yielded, of course, thanks to the availability of a hybrid system. Of course, the same advantages can also be pursued with a hybrid PET-CT system, not just with SPECT-CT. And in comparison to SPECT, PET has important advantages such as higher sensitivity and improved image quality, as well as improved temporal and spatial resolution, which is 5 millimeters versus 10 millimeters. This is about the spatial resolution of both. And furthermore, PET tracers have a more favorable extraction rate, which is more proportional to coronary flow, thus rendering absolute flow quantification feasible and robust. And finally, also attenuation correction with PET is much more robust and reliable. Here I show you an example. Well, in this study by Flotas and co-worker, patients underwent both myocardial SPECT and PET with rubidium. And as you can see, image quality in PET, which is here, is much better compared to SPECT, both without and with attenuation correction based on CT. And moreover, even the presence of significant extracardial activity here is not actually any limiting factor in PET, while it might be a limit in evaluating SPECT. And there is also another very interesting case in which the major advantage of PET is fully recognizable. So in this patient, myocardial perfusion pattern on SPECT is definitely unremarkable. A perfusion PET in the same patient showed only minimal perfusion abnormalities anterolateral, but this examination cannot be defined as definitely pathological. But however, with PET we are able to measure the coronary flow reserve by absolute flow quantification. And the PET-based absolute flow quantification reveals a balanced, severe reduction of coronary flow reserve within the myocardium. And this is consistent either with balanced three-vessel disease or with microvascular disease. So in this case, the patient underwent coronary angiography, which reveals severe stenosis affecting all three major vessels. In this situation, we can see that a hybrid system could really help us making an accurate diagnosis. In our institution, we routinely perform this kind of acquisition. So myocardial perfusion PET is it's quite often combined with coronary CT. And I can show you a very nice case. And here in PET images, we can see a reversible perfusion defect anterolateral, which is probably in the vascular territory of left circumflex artery. In core of CT, we confirmed the presence of a significant stenosis due to a non-calcified plaque in proximal circumflex artery. And finally, we also have the absolute flow quantification showing that a reduced coronary flow reserve is present in the relevant vascular territories. So everything here says that we have a really significant stenosis causing ischemia. The accuracy of hybrid PET coronary CT was also tested in a study of 2010. And in this study, the authors demonstrated a significant improvement in diagnostic accuracy, both on a per vessel basis and here per vessel basis and a per patient basis. And I can see that, of course, the most important gain is in specificity, of course. Thanks to combining CTCA to PET, we also reach 100% specificity on a per patient basis, which is highly remarkable, and also 99% in a per vessel basis. So I think that it's well demonstrated that combining the two modalities yields a much more accurate diagnosis. Another intriguing application for hybrid cardiac imaging is also to characterize the inflammation occurring after a myocardial infarct. Wollenweber and co-workers specifically investigated inflammatory changes after a myocardial infarct. In this image, we have the same patient performed cardiac magnetic resonance, PET perfusion with ammonia, and PET metabolisms with fluorodeoxyglucose. So magnetic resonance imaging shows signs of tissue damage here anteroseptal, that is gadolinium-late enhancement, and also a subendocardial no reflow appearing in black in T2 images. Also a hyperintense region can be detected consistent with transmural edema. And this transmural edema also overcomes the limits of tissue damage. Ammonia PET shows the perfusion defect in the same region in which gadolinium-late enhancement could be demonstrated. And under suppression of myocardial glucose metabolisms, we can observe an increased fluorodeoxyglucose uptake within the infarct area. And this is a clear sign of inflammation. The same authors also investigated the difference between chronic and acute infarct, and while the signs of myocardial tissue damage in magnetic resonance remains unchanged with the time, say that the increased uptake of FDG can be seen only in the acute phase of myocardial infarction, so which is consistent with the post-infarct inflammation, which tend to reduced, of course, in the due course. But of course, hybrid systems are not only suitable to manage patients with coronary artery disease, but also in the evaluation of other pathologies like, for example, inflammation and infections. So positron emission tomography with fluorodeoxyglucose is also a very useful technique for detecting infection, well, because inflammatory leukocytes express a high density of glucose transporters. So this methodology is highly predictive for a metabolically active region. In this study, the authors investigated the diagnostic performance of fluorodeoxyglucose PET in suspected endocarditis. And in this representative image, positron emission tomography combined with computed tomography and geography showed significant FDG uptake around the pacemaker generator. And in the second image here, we have various photos of fluorodeoxyglucose uptake along the pacemaker leads. Also, the use of PET-CT by combining with CTA also allowed for a reclassification of infective endocarditis. And the rate of doubtful cases decreased substantially when PET and CTA were combined, and decreased from 15 cases, that is 20%, to 6 cases, that is 8%. Also, the author investigated also the possibility of adding due criteria to PET-CTA, which allowed also to make a significant reclassification. So 8 of 17 cases were reclassified as either rejected or definitive. And the authors also elegantly show how the simultaneous acquisition of a contrast-enhanced angiography CT yields a significant improvement in diagnostic accuracy. In the first example here, a CT allowed for distinguishes an abscess here constricting the left mainstream, which was not it was not possible to be seen in the regular non-contrast enhanced pictures. And in the second case here, a diffuse cardiac uptake due to incomplete suppression of glucose metabolism causes evident co-registration problems, while myocardial contours were much better delineated on contrast enhanced CT, thus permitting a more accurate co-registration. In this case, after an accurate co-registration, an infectious endocarditis could be excluded. Even SPECT-CT also has an important role in diagnosing endocarditis. SPECT tracers, and specifically radio-labeled leukocytes, are generally more specific than FDG, although the sensitivity is significantly impaired compared to PET. But in this study, Erba and colleagues also demonstrate accurate diagnostic performance of leukocytes SPECT-CT. And sorry again. And this representative image also shows a focal accumulation here of labeled leukocytes both in the intracardiac leads and here in the mitral valve mechanical prosthesis. A different approach using a double radioisotope protocol has been described also in a recent study from our group. So in this example, the patient had initially suspected endocarditis after aortic valve replacement, and planar leukocyte scans show blood pool here, which is uncertain as to whether we have a valvular focus. We also performed conventional SPECT-CT images, and these suggest a potential hotspot in the region of the artificial valve, but still these images are limited by low counts and noise. And on the contrary, here dual isotope imaging show reduced noise and a focal accumulation here localized adjacent to the implant, read as positive for endocarditis. And due to persistent fever and clinical symptoms, the valvular prosthesis was replaced, and at surgery an abscess was identified under the RCA also. And this finding was matching the hotspot on the CZT scan, and so we surgically confirmed the diagnosis of endocarditis. So in our study, also there was evidence of a dramatic improvement of diagnostic accuracy compared both to standalone scintigraphy and with conventional SPECT images, both considering sensitivity, which reached 85%, specificity, which reached 95%. Also, in suspected sarcoidosis, hybrid PET was demonstrated to improve diagnostic accuracy. For example, in this study from Blankenstein and colleagues of 2014, this patient with suspected cardiac involvement during sarcoidosis shows a perfusion defect associated with focal FTG uptake along the basal anterior and inferior septum. Here we have a defect in the perfusion imaging in short axis. They're quite evident, and we have a corresponding hyperaccumulation of fluorodeoxyglucose. Furthermore, we also have throughout the right ventricle multifocal areas of increased uptake, and these findings are consistent with cardiac involvement during sarcoidosis. And finally, we also have to explain the role of hybrid system in the management of patients with heart failure. So molecular imaging eventually combined with CT or MR can monitor many biomolecular pathways associated with heart failure. For example, we can monitor heart metabolism by means of labeled glucose analogs like fluorodeoxyglucose, or fatty acid analogs, or labeled acetate. We also have the possibility to check the activity of the postsynaptic adrenergic receptor or presynaptic sympathetic innervation, especially by means of labeled catecholamine and analogs. We have also the possibility to follow the renin-angiotensin system, the integrin expression, or the matrix metalloproteinase expression, also by means of SPECT or PET tracers. Furthermore, we also have the possibility to check the membrane integrity and the presence of apoptosis and cell death. And finally, last but not least, we can also follow gene expression and reported gene imaging, and we are also able to follow the stem cell engraftment. And molecular imaging aims actually at becoming a trade union, we can define it in this way, so toward the future clinical approaches. So for example, we can say that during the development of a heart failure, we can currently measure the extent of the alteration. This is what we actually do in the moment. And for coronary atherosclerosis, for example, we can measure plaque burden and calcium score. For myocardial ischemia, we can quantify the extent of ischemic burden as well as the extent of a scar. Or alternatively, we also may demonstrate the presence of hibernating myocardium. And when heart failure is more evident, also gated imaging can assess volumes and regional and global ventricular function. And this can also be used, of course, for monitoring the effectiveness of the therapy. But however, what we may foresee in the future is to monitor and detect the early molecular changes able to predict the onset of specific conditions. For example, here, endothelial dysfunction precedes coronary atherosclerosis. And the assessment of vulnerable plaques may also predict the onset of ischemia or myocardial infarction. And in those patients with known ischemia or infarction, many markers of left ventricular remodeling can be traced to predict the onset of heart failure. This is actually the concept of biological imaging. So we do not just provide nice images, but also a comprehensive assessment of biomolecular conditions able to identify precursors. So we have to identify patients at increased risk of developing a heart failure. So in fact, molecular imaging is quantitative and comprehensive, provides insight on cardiovascular pathobiology, can identify patient risk, and can also give prognostic information on disease progression and on therapeutic efficacy. I give you some examples now of future trends in molecular imaging. So matrix metalloproteinase are expressed in a typical manner after myocardial infarction. In particular, we can see that myocardial matrix metalloproteinase 9, which can be detected with a SPECT tracer, have a constant overexpression compared to normal. And this is particularly evident between the 3rd and the 5th day after infection. As you can see here, also the degree of overexpression of MMP9 is significantly associated with subsequent left ventricular remodeling. So in those animals in which a ventricular dilation was observed at follow-up, the expression of MMP9 in the first days after infection was the highest. And here are some pictures of these methodologies. So the in vivo images here show a persistent reduction in counts inferolaterally here. This is a perfusion imaging with thallium and shows this a status post-infection, so it shows a scar. In the same area, in the same moment, an overexpression of MMP activity is evidenced by increased uptake of a specific SPECT tracer, which is RP805. And the subsequent ex vivo dual imaging planner demonstrate a close relationship between SCAR and MMP activation. Moreover, MMP activity is also increased in vulnerable plaques. So in this preclinical study, induced vulnerable plaques in a mouse model were reported to have increased uptake of RP805, which is consistent, of course, with MMP activation. As such, it may be foreseen that the same approach could be used to detect culprit lesions in coronary artery disease, capitalizing on improved spatial and temporal resolution of modern SPECT cameras. Another important determinant of heart failure is apoptosis, which can be effectively traced through annexin. In this picture, an animal with a normal perfusion pattern on SPECT have increased uptake of annexin scar. Here and here. And there was evidence of heart failure progression in this animal. In this picture, there is an evidence of an increased annexin uptake septoapical, and in the follow-up, as evidenced by a subsequent perfusion scan, we also have a scar in the affected area where we had annexin increased uptake in the previous examination. Finally, also integrin expression as detected by RGD peptide can be used to predict neoangiogenesis and ventricular remodeling. And the correspondence between histology and SPECT has been fully demonstrated in this study. And in this image here we can see there is the evidence of active myocardial remodeling anteroapically. Another intriguing possibility is to characterize the vulnerable plaque in vivo. Hereby I show you some pictures from the paper from Joshi and co-workers published in Lancet in 2014. This patient had a proximal occlusion of the left anterior descending artery on invasive coronary angiography here. And hybrided fluoride PET-CT images show intense focal uptake, it's here, at the site of the culprit plaques. And the corresponding FDG PET actually showed no uptake at the site of the culprit plaque. And interestingly, the authors also compared the findings of hybrid images with ex vivo imaging and autopsy. So in vivo here and ex vivo images, well, they show a clear co-localization of fluoride uptake to the site of plaque rupture. And here we can see that we have an adherent thrombus on excited carotid endarterectomy tissue. And histology here also showed that the region with increased uptake show a large necrotic core, and we also have signs of active calcification. So, well, in order to conclude our webinar, I think I have to give you some take-home messages. So I think hybrid systems allow for combining anatomical and functional information. And compared to standalone modalities, hybrid systems yield improved diagnostic accuracy and reader's confidence. Furthermore, hybrid systems allow for a tailored prognostic assessment which is superior to that of standalone modalities. Finally, also many biological targets can be detected by molecular imaging, and hybrid systems allow for a precise localization. And now we have to come back to our first question. So what could be an answer? So actually, given the large body of evidence confirming a pivotal role of hybrid cardiac imaging in many regards, I would for sure say that these methodologies represent a workhorse for the present and also for the medicine of the future, which will be more and more based rather on the paradigm of causative physiology rather than on resultant anatomical changes. But actually, I would also say that these techniques are also a very amusing toy. So as Gerhard says, the whole life is rather a game in which we play looking for something that is not yet here. And we need to play to look for new discoveries which constitute a new important step toward the medical needs of the future. So I thank you everybody for the attention, and if you have some questions, I'm here for you.
So thank you very much, Federico, for this really outstanding lecture. You covered, and I think exhaustively answered the main title of your lecture, which was triggered in the presentation. We usually wait 1 or 2 minutes for people connected to write down a question to myself or clarify any of the doubts that may have raised from this fantastic lecture. Is there anyone who would like to ask any question? Let's wait a second more. So meanwhile, maybe I could start with a general question regarding the trend. I think you are a nuclear specialist. There is a trend in Europe that specialties are fusing, starting from the Netherlands and spreading all over the country, in which I'm all over the continent, of which I'm really in favor of. And as you showed, talking about hybrid cardiac imaging, it's really the future. So what's your position and what's your idea, and how you integrate your work with the, let's say, the pure radiological part regarding cardiac imaging, because really I think, in my opinion, it doesn't make sense anymore to talk about radiologists, cardiologists, or nuclear specialists. It's more related to competencies. So what's your approach to this general, let's call it political question, and then we will go to the focus of your lecture, of course.
Well, the political question, in my opinion, should focus also on the needs of the patient. So, well, we demonstrated that it's a real advantage for the patient if we have a combined methodology. So if we have hybrid images, and if the patient, the methodologist can have an advantage coming from different competencies, so radiologist from a side and nuclear medicine from the other side, I think it's just beneficial for the patient and for everybody. So actually, as we do normally in our clinical practice, we have a very strict connections with the radiologist, so we cooperate almost in every part of our job. And this helps, of course, because everybody has his own background, cultural background. We are stronger, of course, in molecular imaging. Maybe the radiologists are more stronger in anatomical imaging. But if we combine our expertise, I think the result is, of course, results in an improvement of care, of health care for the patients. So actually, yeah, I agree with you when you say that probably it's a bit outdated, it's old-fashioned to speak about radiologists and nuclear medicine. I think we are just doctors, experts in cardiac imaging, and everybody has, of course, his own competence, and all the competencies have to be put together in order to achieve the best possible results.
So thank you very much. I fully agree with that, and I think as again a political statement, ESCR is working in this direction with nuclear colleagues. We are preparing documents and whatever, so it's really not only the future but the present. So any question from the colleagues connected? It's nice because we still have a lot of colleagues following the discussion. Don't be shy. We can just you can just forward me the question. I will be happy to read it for you. Otherwise, I would go to your lecture specifically and focusing about hybrid systems in heart failure. What would you think? Is it unrealistic to foresee a wide deployment of molecular imaging targeting precursors in this specific setting? How do you see this issue?
Well, I see that it's a future. Well, it's not still the present because, of course, of the fact that we are still on a preclinical assessment. So these methodologies are showing very promise in the preclinical assessment, but as a matter of fact, a clinical application has not been pursued anymore. But still, if we tend to identify precursors in order to be able to prevent the onset of a disease, I think we cannot help assessing the very early precursors. And in this sense, I will think that once the cost will be affordable, because of course in this situation we can say that the cost for identifying a precursor is almost 10 or 20 times a normal perfusion scintigraphy. So of course is in moment with financial problems in Europe and the US, of course it's not possible to foresee an application in the next future, but still in the sooner or later I think we have to face that, and I'm pretty confident that in, let's say, not in a faraway future, but also not in the next future, I think we will be able to provide also these advantages in the clinical practice.
Okay. Any other questions or comments, or I will keep the discussion? Not yet. So a second question also about molecular imaging. Do you think it can assess intimate molecular changes preceding the onset of a disease? And can these targets be suitable also for targeted therapy? So following what we just
I think, yes, of course. Well, one of the most important advantages of molecular imaging is to be able to trace the intimate changes before the anatomical changes, of course, and of course before the onset of the disease is evident. But of course, as it happens with oncologic applications. So if we identify potential targets with the diagnostic imaging, then of course we can also foresee, we can also speculate that we can use the same targets also to assess, to perform a targeted therapy. So for example, with the vulnerable plaques, it's questionable, but it's also debatable, but it might be an interesting area of application if once identified, the vulnerable plaques will be able to use the same tracer, maybe of course coupled and labeled with the beta emitter so that it is able to perform a therapy. And we can use this approach also to destroy these vulnerable plaques. So I think yes, we're just at the beginning of the road, but of the trip. But I think this is also a very important application for the future.
Okay, thank you. No questions. So one more, well, very general question from my side, keeping the level for non-imaging experts. So I worked in a big university department. We don't have hybrid imaging. And even being, let's say, a cardiac expert, I'm always a little confused about current and future role of different techniques. So if you would, with a flash answer, give us your idea in the setting of ischemic heart disease about a role, current and mainly future role of CT, including CT perfusion and tissue characterization versus MR, versus PET-CT, versus PET-MRI. How would you imagine the combination of these techniques? I know it's a complicated question, but there is an overlap, of course, in terms of information. How would you integrate? It's a more
it also
basic
depends
question, but
on
just try.
what we have. I think, well, in the future, we still have to focus that the most important thing is what we are going to look for. So, and depending on what we are going to look for, the different combination of all the techniques will be highly desirable. As I showed you also before, we also have the possibility of using two different radioisotopes if we are performing a SPECT. So this is not actually so trivial. Well, the advantage is that if we use two different radiopharmaceuticals, then we are able to trace two different alterations. So for example, we might use a perfusion imaging while we are checking for annexin expression or RGD peptide expression. And all that can be coupled, of course, with anatomical imaging and also for anatomical and functional imaging using MR. So I think that in the future, if I can imagine everything, I think that none of these techniques will disappear, but I think that they will be combined in a tailored way depending on the clinical need we have.
So I assume, because I was impressed of the provocative title. Last September we had the European Society of Cardiology meeting in Rome, and one of the lectures focusing on ischemic heart disease in general, so without a specific background, entitled SPECT Imaging, Is it the Death of a Giant? Because of the limited spatial resolution. I assume, at least currently, you would not agree with this, or what's your idea?
I agree partially. Well, I also said in my presentation that SPECT is limited by a lower spatial resolution. Well, we also have to keep in mind that now we have some heart dedicated camera system. They are equipped with cadmium zinc telluride detectors. And in this situation, the spatial resolution is much more similar to that of PET. So, and I also have to say, in comparison to PET, the radiopharmaceutical we use in SPECT are more readily available, so we don't need a cyclotron, even regional or on-site cyclotron, and the most radiopharmaceutical can be prepared as kit in every laboratory. So actually, SPECT up to now has, of course, great advantages, which is the availability in comparison to PET, and also the cost. SPECT costs much less than a PET scanner. But still, and if we use this hard dedicated camera system, we can also partially overcome the limitation of SPECT. In my study, of course, where the study showed, we reached with this double radioisotope protocol a similar sensitivity and specificity of that of PET. So SPECT, yes, it's not exactly the fall of a giant, but of course, I think to survive the test of time, they also have to perform some more innovations.
Okay. And also, what emerged from literature, most of the trials comparing, for example, SPEC with MR were based on a known state-of-the-art technology. So that's another issue to consider. And also, as you
Yeah,
said, it's fully available. Everyone is doing it. So PET is, of course, is completely different, several advantages, but that's the
yeah, of
state of the art.
course. Which is
Uh,
quite understandable. Also, JARMA also published a very interesting meta-analysis and review comparing MR, PET, and SPECT. But of course, studies with new hardware system are hardly available up to now.
yeah.
So still,
So
probably
it's
this meta-analysis should be repeated in a couple of times. But of course, I'm not saying that MR will be proven inferior to SPECT. I
yeah,
think it would be too much to think
yeah,
about that. But probably SPECT is not so just a toy, but can be also a workhorse.
yeah. So Federico, thanks a lot. I think I don't see questions. It's a shy audience today. My opinion, first of all, you did a great job. You really convinced us that it's not a toy, it's going to be a workhorse, and encourage our effort as society to more and more integrate hybrid imaging in our talks, because really looking at the problem, let's say, of ischemic heart disease, of cardiomyopathies or whatever, only based on a limited availability of techniques, it's not a full vision. So I think we can finish 5 minutes in advance, but it was really comprehensive, and thanks a lot to you for supporting for supporting our society and our webinars.
Okay, and thank you everybody for the participation.
Thank you. Bye bye.
Okay, bye.
Bye.